Okay, hi. Hello, everyone, and good evening, maybe good morning or good afternoon to some of you. And thanks again for joining one more session of the Innovation and Precision Eye Health webinar series. So today it gives me great pleasure to host Dr. Gareth Lingham to give us a talk about time spent outdoors in the management of myopia. And Gareth will be giving an Australian perspective about time outdoors and the myopia. So before we start, let me introduce Dr. Lingham first. So Dr. Gareth Lingham is a vision scientist and orthoptist specializing in myopia and ocular epidemiology and population eye health. He is currently a research fellow at the Lions Eye Institute and the University of Western Australia, where his work focuses on understanding environmental, genetic, and behavioral risk factors influencing eye disease across the lifespan. So Dr. Lingham completed his PhD in ophthalmic epidemiology at the University of Western Australia and holds a Bachelor of Health Sciences and Master of Orthoptics from La Torbe University. His research spans clinical trials, cohort studies, and global eye health initiatives with particular interest in myopia prevention, ocular sun exposure, and public health strategies to reduce vision impairment. Beyond academia, Gareth contributes internationally to eye health policy and research collaborations, including advisory work with the World Health Organization and industry partnerships such as Ocumetra. He previously held a postdoctoral and academic role at the Technological University of Dublin. And today, Gareth will be talking to us about a problem that we have quite a lot of in Singapore, which is myopia, which is of epidemic magnitudes in Singapore. And around 60% of our kids, when they reach P6, are already myopic. So technically, we advise parents to take the kids outdoor to prevent that onset of myopia. And today, Gareth will be giving us his perspective and talking to us about his research and time outdoors for myopia management from the Australian perspective. So in addition to this, we will be joined by two panelists from NUH and NUS Ophthalmology, Dr. Sun Chen Sin and Dr. Janice Slam, both who are pediatric ophthalmologists who are very specialized in myopia and see a lot of the cases of myopia around Singapore. And we will have a very interesting discussion after Dr. Lingham's talk together with the panelists. And please feel free to ask your questions in the Q&A as well to join the discussion. So Gareth, thanks again for agreeing to give this talk, and we look forward to what you're going to say. All yours.
Thanks, Ray. I'll just share my screen there. Okay, we're away. Thanks so much for that kind introduction and for the opportunity to talk to you all today. It's wonderful to see so many people signed in and interested in myopia management and outdoor time. So as Ray mentioned, I'm very much going to talk about the Australian perspective, and we have a range of sun-soaked environments in Australia, ranging from subtropical in the north through to temperate in the south. So I'm located currently in Melbourne, which is the city that's second furthest south, but I spent a lot of time in Perth. I've got a few things to talk about today, and essentially the first half I'm going to talk about myopia quite a lot and myopia progression and how that relates to outdoor time. And then the second half I'm going to talk a bit about the other effects of spending time outdoors that aren't related to myopia. Some of them are benefits, some of them are harms, and some of the population health interventions that have actually been going for a long time in Australia, but again, are not related to myopia, more related to skin cancer, which is out the end of the spectrum there, spending time outside. Now, before I go any further, I do want to acknowledge all the people who have contributed to this work, and particularly Professor David Mackey, who's on the right there, who's I did my PhD with in Perth, as I work with at the moment, and Dr. Samantha Lee, who is actually from Singapore, but again, a key contributor to our lab and currently living in Sydney. As a bit of background, I won't spend too long on this, but myopia prevalence has been increasing right around the world, but most dramatically in Singapore and other cities of Southeast Asia and East Asia. And approximately 80% of 20-year-olds in Singapore have myopia. if we compare that to Australia, it's about 25% of 20-year-olds have myopia. So it's a huge difference there. We are seeing a slight increase in myopia prevalence in Australia, although we really don't have much data to support this. The one set of data we have, it came out of Perth, and we showed that there's been about a 5% increase in the prevalence of myopia in adults born after 1945 versus before 1945. And these are adults aged 49 to 64 years. So for anyone born after the year 1964, we don't actually have any data as to whether the prevalence of myopia is increasing or not. And that's certainly something that we really need to address in Australia, and we're a long way behind Singapore in that respect. What's driving the increases in myopia? There's three main environmental factors that we talk about. That is not enough time outside, too much time in education systems or very intensive education systems, and too much time doing year work. And they are all related and intertwined in various ways. Genetics does play a role. In rare cases, it can directly cause myopia, but more often it's probably altering whether you're susceptible to those environmental influences or not. So it might slightly increase your susceptibility to myopia or slightly decrease it. And we worry about this because there are complications of myopia, and particularly high amounts of myopia. And these are things like glaucoma, retinal detachment, and myopic macular degeneration. And the risk of these conditions really goes up fairly exponentially as you become more and more myopic. So as the severity increases. And for example, I've compared two populations on the left here. So this purple distribution is Western Australian young adults. And you can see most of them, the height of the peak represents how many people are in that area. Most of them sit in the emetropia area. If you compare that to some medical students from China who came to visit us over the winter, you can see that they have this big, they have no peak, and most of them sit in the myopia range, and quite a large proportion sit in the high myopia and very high myopia ranges. And that's really concerning because they're at very high risk of complications later in life. Now, the Sydney Myopia study in Australia was actually one of the first studies to show that spending time outside decreases your risk of myopia. And they conducted a 5-year follow-up of the same participants and showed that if you spent more time outside at baseline, your 5-year risk of myopia was also lower. And that was independent of year work in both occasions. So that was some of the really core evidence we had that spending more time outside actually reduces your risk of myopia. We don't know how this works. This is a review I wrote a few years ago now, but some of the key candidates are probably brighter light. So that's very strong evidence that the brightness of sunlight outside sends signals to your eyes to stop growing. But there might be other factors associated with being outside as well. Things like the chromatic composition of light. So there's more blue and violet lights in sunlight compared to the artificial light we use inside. There's also different amounts of stimuli outside in terms of spatial frequency. So things like there's fine detail in the leaves and the grass, but there's broader detail in the trunks of the trees and the branches. And that variation might be signals that our eye can use to determine whether it's too long or too short. That also plays into contrast, which some of these optical treatments to slow myopia progression use. So there are contrast modifying spectacles that we know can actually slow the rate of myopia progression. So for my PhD, I worked on the kid skin study where we aimed to investigate whether time outside in children actually has long-term benefits for reducing myopia risk. So the kid skin study was initiated in Perth in 1995, and children aged 6 years were enrolled into the study. And the study was aiming to reduce their risk of skin cancer. It had nothing to do with myopia at the baseline. Children were enrolled assigned to either control intervention, a moderate intervention, or a high intensity intervention group, with the intervention groups receiving educational material about how to avoid sun exposure or to reduce sun exposure. And they were then followed up again at age 8, 10, and 12 years, and parents completed questionnaires on how much time their child spent outside at those follow-ups. You can see the intervention actually only went for 4 years, and then they had a 2-year post-intervention follow-up. And about 1,800 kids were enrolled. So first of all, did the intervention actually work? It did. So there was good evidence that the children in the moderate intensity and high intensity intervention groups had less sun exposure based on those questionnaires at the 2 and 4 year follow-up, so when they're age 8 and when they're age 10. And the aim of my study, which was called the Kids Getting Young Adult Myopia Study, was to try and find those same participants of whom they're 1,800 and to see whether they'd become myopic or not. So they were aged 25 to 30 years when we did the KEM study. And we managed to track down 303 participants and convince them to come into the clinic where we assessed whether they had myopia. And we were able to look at whether the intervention had an effect on their risk of myopia. So did the children assigned to a moderate or high intensity intervention group have a lower or higher risk of myopia? Now, we actually thought they might have a higher risk because they would have less sun exposure, but we didn't find any significant differences in the risk of myopia across the 3 intervention groups, noting about 29% of the cohort had myopia. We can do an observational association where we look at, well, how much time did the parents actually report their children spent outside? So we're not worrying about intervention groups anymore. We're looking at how much time they were reported to spend outside in summer and whether they were myopic or not. So this 1997 box is at age 8, and we didn't find any difference in the amount of time children spent outside at age 8 versus whether they were myopic or not as an adult. But you can see at age 10 that the people who were myopic as an adult actually spent less time outside at age 10 compared to those who were not myopic. And then again at age 12, the adults who were myopic at age as an adult actually spent less time outside at age 12 years as well. So that's one thing we can do. We can look at questionnaire data, but it's very hard to recall sun exposure either for your child or for yourself. We tend to overestimate slightly. That's pretty well known, and it can be imprecise. And that's not through any deliberate sort of inability, but it's just hard to recall what you accurately did over the last week, month, year, and sometimes we even asked about 10 years or 20 years ago. So we have a range of subjective measures, but we still want to use these data. And so we have parent questionnaires from age 8, age 10, age 12. And we did ask participants when they came in as an adult to recall how much time they spent outside for every year of their life from age 5 onwards. So you can imagine that's a tricky task. We did try to verify whether those responses were in any way useful, and we found that for the last 10 years or so, they were useful. So not surprisingly, if you try to remember what you did 20 years ago, it doesn't work very well. But the more recent past, we were able to use the responses for those ages. But we didn't rely just on subjective data. So what we're doing here is calculating an index variable. So we're trying to combine multiple measures to get a better estimation of outdoor time. And so we looked at vitamin D because we know vitamin D is produced in response to sun exposure. So if UV hits your skin, there will be vitamin D produced in response to that. And this graph shows that your vitamin D actually takes out 3 weeks to peak. So if you have an exposure of UV at baseline, about 3 weeks later, your vitamin D rises, and it's sustained for about 4 months or so before it drops off again. So it's a marker of how much time you spent outside about a month ago, between 1 and 4 months ago. So it's a really short-term measure of outdoor or sun exposure. We looked at skin damage. So these are casts that we took of the back of their hands. It's just of silicon, and you get these amazing kind of patterns. But the cast on the left shows a healthy skin. So you have lots of fine lines running and regular lines running across it. Whereas the cast on the right shows you a very damaged skin cast, where there's a lot of what we call elastic degeneration of the skin. And so you can assign a score to these skin casts. That goes from 1 to 6, and this correlates pretty nicely with cumulative lifetime exposure to the sun. Noting in the KidSkin study, we actually found that most participants had 5 or 6. So we had a real ceiling effect where most people had very damaged skin, even at age 30 years. We looked at conjunctival ultraviolet autofluorescence, and this is this bright blue area here, which is on the white part of your eye, the conjunctiva, and it autofluoresces under a UV flash. So it's just a brief flash of UV light that makes it fluoresce here. And the larger this area is, the more time you spend outside in the sun. So it correlates pretty nicely, or the area of this QVAF is what we call it, correlates nicely with the amount of time that people spend outside. So we have all these fantastic measures. We have these questionnaire measures, we have these skin damage, QVAF, vitamin D, and self-reported measures. And I looked at combining them into a sun index using a statistical analysis called confirmatory factor analysis. And what this does is trying to look at the shared parts between all these measures, because they're all measures of sun exposure or time outside in the sun. It's looking for the bits that correlate with each other within those variables, and it assumes that those are true measures of some underlying variable. In this case, it's time spent outside in the sun. And when we did the analysis, it turned out that actually it worked better as having two sun indices rather than one sun index, which represented your whole life. It worked better as having two, so one that represented childhood and one that represented recent sun index, with the skin score and the parent questionnaires going in the child sun index, which makes a lot of sense in how we collect those. And then vitamin D and recent sun exposure going into the recent sun index. Again, makes a lot of sense to how we understand these variables work. So when we looked at the childhood sun index and the recent sun index, what we found was that participants who were in the bottom quartile of sun exposure, that's in the red bar, compared to those participants, those in the top two quartiles had about half the risk of myopia as an adult. So we're seeing about a 50% reduction in the risk. These bars show that's not significantly different, but the trend across the four quartiles was. And if we, the recent sun index wasn't as obvious, but again, the top quartile certainly had a lower estimate or a lower prevalence of myopia, but it wasn't significantly different there. If we looked at the difference between the top and the bottom quartile in the sun indices, the top and bottom quartiles of amount of time spent outside, it was about 1 and 3 hours with a difference. There's about a 2-hour difference between children who spent the least amount of time outside and children who spent the most amount of time outside. And so that probably holds up, that we recommend at least 2 hours outside per day. Those people who had the 3 or more certainly were at half the risk, and I imagine that risk is certainly reduced at 2 hours. Now, since this work, this was useful work for showing that time outside as a child has long-term benefits, but this the best study design is a randomized controlled trial, and there's been work out of China and Taiwan showing that if you randomize children to spend their lunchtimes outside or increase the amount of time they spend outside, that there is a reduction in the rate of development of myopia. And that reduction is between 10 and 23% reduction in the risk of developing myopia over the next 2 years or so. And so we have really good evidence that time outdoors both reduces incidence of myopia and has some long-term benefits in terms of reducing your risk of myopia. And that's led to countries like Singapore and Taiwan implementing messages to increase children and teenagers' time outside as a public health intervention. So I recommend that all children spend more time outside. So in Taiwan, they recommended 2 hours outdoors per day, NEOC breaks, increased room lighting, and changing the table height. And they did actually find that there was a reversal of their trend of increasing myopia prevalence. So after this public health intervention, the estimated prevalence of myopia started to decrease. They didn't actually measure myopia using the gold standard, but it was an estimate. The bottom right graph shows the data from Singapore. Again, it's an estimated prevalence of myopia, but it seems to have decreased in the primary school age group after implementation of a public health intervention, and then been relatively stable since, whereas there wasn't much change in the secondary school group. So that's one very legitimate approach to this. You can recommend all children in a country or a place spend more time outside and as a way to reduce their risk of myopia. You can also look at doing it as a targeted intervention, and this might be more useful for places where children are inherently lower risk of myopia, and that's like Australia, where probably only 25 to 30% might become myopic compared to 80% in Singapore. So we could find children who are at the highest risk of myopia and recommend that they spend more time outside while we don't intervene with the rest of the children. This has some tricky components to it. So the first one is identifying children at the highest risk of myopia. And we could do things like ask if their parents are myopic, but there'd have to be some sort of screening involved to identify children who are at the highest risk of developing myopia, and then implement the recommendation to spend more time outside. The second tricky part to this is, how do you actually increase their time outside? So we can ask them to spend more time outside, but we've been doing a fair bit of engagement with parents and children around this, and the consistent feedback is it's not that simple. And so we're looking at, what are the things that we can change to actually encourage kids to go outside? What's going to enable them to go outside? And what are some of the things that are stopping them going outside? So things that are stopping them would be barriers, so things like lack of safe spaces, environmental conditions. That's could be smog, it could be bushfire smoke in Australia, and lack of peer support, just not having friends who would go outside with them, was essentially what I mean by that. And then some of the enablers might be things like organised activities and sports. And again, feedback has been it needs to be flexible, because some people like before school, some people like after school, and there's a whole different range of schedules to fit in with. One problem with the targeted approach is that there's some recent data from the STORM study in Shanghai, and they looked at the amount of time children spent outside and then tracked how much their myopia changed over 12 months. And the group who had pre-myopia, so they're at the highest risk of developing myopia, didn't have much of a response to spending more time outside, because this line here is pretty flat, which means that as they spent more time outside, there wasn't much of an improvement in their myopic shift over 12 months. And it's only after about 90 minutes that we started to see an uptick in that. So there was a bit of a potential benefit after 90 minutes, but the group difference between the top and the bottom was not significant. And then on the other hand, for those who had hyperopia, so are at lower risk of developing myopia than the pre-myopes, there was actually a much more obvious and stronger trend. So that as they spent more time outside, their myopic shift over 12 months reduced, and that benefit started to run out after about 90 minutes or to 2 hours. And there's a lot more work to do in this space. It's not certainly the end of the road here, but it's just some early data suggesting that maybe the pre-myopes, so the people at highest risk of developing myopia, don't respond as well as we might hope. So on to the next question, which does come up a bit. We've looked at how outdoor time prevents the onset of myopia. There's a bit of a question about whether it also reduces myopia progression. So if you're myopic already, does it slow the rate at which your myopia gets worse? And this is a systematic review of systematic reviews. So there's been quite a few reviews on this already. And you can see that they all find, on this side of the line, they all have a finding that favors higher exposure. And that just means that they're all estimating that, yes, if you go outside more, you're having less reduction or less myopia progression. And it's pretty consistent, but it's only about an eighth of a diopter. So it's a small effect, but a consistent effect. There's actually data that's come out more recently that's not shown in these graphs. This is again from the STORM study I just mentioned, but they randomized children to control, an extra 40 minutes outside, an extra 80 minutes outside. Children in the intervention groups had less myopia progression and less axial elongation over 12 months. Again, the differences are small, so maybe a quarter of a diopter, about 0.1 millimeters in axial length. They did actually find a dose response though, which is nice, so that the children who spent the most time outside had the least amount of myopia progression compared to those people who were only just reaching the threshold. And there was another study again out of China showing that the children who had more outdoor activity, slightly less myopia progression than the children who had less outdoor activity. So we're finding pretty consistently that there's a benefit, but it's a small benefit. Still a benefit. I should note that because outdoor time is really cheap, it doesn't cost the healthcare system or families much, still has a generally favourable cost benefit profile. What about myopia control? So if you're using a myopia control treatment, that's a treatment that slows the rate of your myopia progression. How does outdoor time affect that? So there was some evidence from COVID-19 that maybe myopia progression had increased. And we actually, at the time I was in Dublin working on the Mosaic trial, where we randomized children to either 0.01% atropine eye drops or placebo eye drops, and we tracked their myopia progression. Now, the grey box I've shown in the graphs here is actually where there were social restrictions in Ireland. So it was about a year nearly where there was limited movement. And then out the other side of the grey box is when social restrictions were dramatically eased and children started going back to school and things like that. And you can see that in terms of myopia progression, the two groups really tracked together up until the end of that COVID, of the end of the social restrictions. And then after the social restrictions eased, then those groups started to separate more. And so the implication is this is not definitive evidence, but it implies that that social restrictions, which increase your amount of time inside and more time on laptops because you're doing school on laptops, actually reduce the effectiveness of atropine 0.01% eye drops. So not just that it's increasing the rate of myopia progression, but it's actually making atropine less effective. And so that's really, really early evidence. We can't say it's for sure at the moment. There was a study on dim spectacles which didn't find the same difference. In the WA Atom study, where we looked at 0.01% atropine versus placebo. This is in Perth. We did find the same effect. So that 0.01% atropine. Sorry, this is a busy table, but the significant value is here in the bottom right. But the children in the 0.01% atropine group had faster progression during COVID-19 compared to the placebo group. And we're further looking at this at the moment in Australia, running a project looking at the amount of time children spend outside, the amount of time children who are receiving a myopia control treatment spend outside, whether it actually modifies the effect of those treatments. Speaking of modifiers, there is one other thing that's relevant to Australia, but perhaps less to Singapore. This is season. And it's been well known for quite a while. This is data out of the US from over 10 years ago, showing that myopia progression is slowest in their summer, and fastest in their winter. And that holds up. This is data from China. Children on ortho-K, again, faster progression winter, slower in summer. But there's quite a few studies out there which all pretty much show the same thing, that myopia progression and axial eye growth tend to be faster in winter and slower in summer. I was able to look at the same thing in myopic children of the Mosaic study on the left and then the WA Atom study on the right. So in Ireland, it was as we expected, summers around June and July. So the rate of eye growth in summer was at its lowest. And then the rate of eye growth was at its fastest in December and January, which is the middle of winter. And in Australia, because we're in the southern hemisphere, the whole thing flips. Our winters are June, July, so we see a peak in eye growth around June there. And then our summers in December, January. So we see the lowest rates of axial eye growth in December and January. And this is important. As I said, this is an Australian perspective. I'm not sure that the effect is in Singapore, but in Australia, it's really important because if you put a child on myopia control treatment just before summer starts, they're naturally going to have slower progression because of summer. And so you might see them 6 months later, which is the standard recall, and you'll think your treatment's working really well. But in fact, it's just summer. And you get through winter and you go, oh no, my treatment doesn't work anymore because suddenly they're progressing faster. And vice versa if you start them on treatment just before winter. So it's quite an important consideration. In the WA Atom study, the amplitude is 0.06 millimeters per year. That's from the top peak to the bottom trough is twice that, so 0.12 millimeters per year. That's quite a reasonable effect. The average effective treatment in the same study at 12 months was 0.09 millimeters, so actually slightly less. So it's not to be discounted in data where, and these are all locations that are away from the equator, so we're having a reasonable difference in day length. What about non-myopic children? So I've showed you some data from myopic children. We're currently examining some children in Perth who are aged 5 to 13 years. They're part of the RAIN study, but it's not that relevant for this. But we're seeing them every 6 months and looking at their seasonal changes. And we're only seeing them in spring and summer. So this is our spring here on the left and our summer on the right. And the green dots are myopic children. So there's only a few of them in among the whole cohort. But we could pretty easily find the same curve or the same seasonal change in eye growth, with it being at its lowest in summer, in late summer, and at its highest in winter. So why do we see season varying, or why do we see myopia progression varying with season? And the obvious explanation for us is day length. So in Perth, we have about a 4-hour difference between day length in winter versus summer, and it's a pretty significant, it's pretty obvious and significant variation across the year. In Singapore, your day length is almost static. It changes by minutes rather than hours. So it would be really interesting to know if there is some seasonal change in Singapore. And if anyone has data to look at that, I'd be really interested. Please get in touch, because I'd be interested in knowing whether that's the case. In fact, it'd be a good experiment, because the other explanation is school holidays. So if you're in the summer holidays, you're not at school, maybe you're spending more time outside, maybe you're not doing your studying as much. And so that behavioral change is what's actually triggering the slowing of myopia progression in summer. Now, in Singapore, obviously your day length is static, but you still have school holidays. So if there were a seasonal change, it would be driven by behaviors. If there wasn't a seasonal change, it would be driven by day length. The last factor I've got there, IOP, or intraocular pressure, that's pressure inside the eye. There's some weak evidence that higher intraocular pressure can actually increase the rate of myopia progression. It's pretty debated, but we do actually see a seasonal variation in intraocular pressure. And this is in the RAIN study generation 3. So this is in about 100 kids. We can pretty easily find this. It peaks in winter and is at its lowest in summer. And I was able to overlap the two curves. So green is axial length and yellow is intraocular pressure, and they peak and trough about at the same time. Look, so they correlate, but that doesn't necessarily mean they're causative. So on to the second part of this talk, just talking about some of the non-myopia benefits of outdoor time and potentially some of the harms as well. So benefits, and I do want to take a moment to really emphasize this, but reducing myopia progression or preventing myopia onset is not the only benefit of being outside. And there are a lot of other reasons why children and teenagers and adults should all go outside. Things like vitamin D, which is really important for bone health in kids, and probably has some immune effects in adults as well, and teenagers. So that can be supplemented, but outdoor time is a good way to also get vitamin D. There are some short-term cardiovascular benefits that have been shown. Long-term we don't know about yet. There's pretty reasonable evidence that it improves mental well-being. People who go outside more tend to be happier and report higher well-being than people who don't go outside as much. And then there's the factor of multiple sclerosis, which is a bigger factor in Australia, where we have a higher rate, but there's a well-known gradient that people who live further away from the equator tend to be at higher risk of multiple sclerosis, and we think that's related to sunshine and specifically to ultraviolet radiation. Now, there's also some harms to going outside, and I don't think this should necessarily put people off, but it's worth having the whole picture in mind. So when we think of harms, we think of largely ultraviolet radiation-related conditions. And these are pterygium, this is the growth on the conjunctiva here, cataract here, which again, age is a really big factor in cataract. So ultraviolet's a relatively small part of that. And skin cancer on the right there. And these are some of the potential harms. Now, I've shown you that sun exposure, and we'll get to some more evidence in a moment, but I've shown you that sun exposure is probably related to, it's related to myopia, cataract, pterygium, and skin cancer. And so if you think of these conditions all arising from a common source or having one common contributor, not necessarily the main contributor, but a contributor, then we should actually start to see correlations between them. Because if you have high amounts of time outside in childhood, you won't get myopia, but you'll get a pterygium and skin cancer. And so I looked at this in the Busselton Healthy Aging Study. Busselton's a rural town about 2 hours south of Perth. We have nearly 4,000 participants, most of whom are of white ancestry or white ethnicity. And we looked at some of their skin cancer and eye conditions. So The first thing I did was look at whether I look at the prevalence of myopia in people who do and do not have a pterygium or have had a previous pterygium excision. And so this graph shows that 18% of people without a pterygium have myopia, but only 12.9% of people with a pterygium have myopia. So people with a pterygium have a lower risk of myopia, which makes sense because they've spent more time outside early in life, lower risk of myopia, higher risk of pterygium. And that's a significant difference. So about 50% increase in the risk of, or 50% decrease in the risk of myopia with the pterygium. We can look at the same thing with skin cancer. So if you spend more time in the sun, you'll have a skin cancer, but not myopia. We see a slight difference here, 15.8% prevalence of myopia in those with a skin cancer compared to 17.8% in those without a skin cancer, and that's not significantly different, but going in the direction we expect it to. We can look at pterygium and skin cancer. So this time we expect them to be positively correlated because if you spend time outside early in life, you have a pterygium and you have a skin cancer. And we see that, yes, people with a skin cancer have a prevalence of a pterygium prevalence of 17.3%, but people without a skin cancer have a lower prevalence of pterygium. Again, a significant difference, so about a 40% increase in risk of pterygium if you have a skin cancer, and you could actually think of going both directions. And skin cancer is, unfortunately, Australia's national cancer. We have a load of them. We have the highest incidence of cutaneous melanoma in the world alongside New Zealand. It's the third most commonly diagnosed, this is cutaneous melanoma, is the third most commonly diagnosed cancer in Australia. It's in the top 10 leading causes of death from cancer. It's a big problem. Basal cell carcinomas and squamous cell carcinomas are known as non-melanoma. They fall under the umbrella of non-melanoma skin cancers, and these are the two most common causes or types. In Australia, they account for more cancer diagnosis than all other cancers combined every year, and are very expensive purely because there's so many procedures to have them excised. They don't have a low rate of mortality. They do are attributable. They do cause some mortality, but certainly the cost is probably a huge factor in this. And we've seen in Australia that the incidence of melanoma, so the more deadly of the skin cancers, has been going up for 30, 40 years, both in men and women. And we have a much higher incidence, you can see, than other countries with European ancestry, populations of European ancestry, although they are also seeing a rise. And this prompted in the 1980s a public health intervention. So this is Sid the Seagull, and this is a Slip Slop Slap campaign, or also known as the Sun Smart campaign. But he encouraged you to slip on a t-shirt, slap on some sunscreen, and slap on a hat. And this was targeted at schools. So every kid going to school in Australia would be very familiar with this. I certainly remember it. It's quite embedded in the psyche. And it's been around for 40 years now. They've added on seek and slide, so seek, shade, and slide on some sunscreen. So it's evolved a little bit, but it's still Sid the Seagull and still the basic messages. And when we talk to 6-year-old research participants, some of them can name, all of them can name at least one of these S's. So they're already at that age, having the sun protection messages drilled into them that this is, need to be sun smart when outside. And it's really interesting. This has been having an effect. So we're still seeing melanoma incidence rise. This is the red line on top in all ages. But this is being entirely driven by the populations aged 50 years and older in the yellow line. And the younger population is actually having a declining incidence of melanoma. And this is the group who were exposed to the public health intervention during school years. So these people aged 15 years and over sort of missed the boat. But these people in blue were young enough to be in school when the Slip Slop Slap campaign was introduced. So we are seeing this effect in people who are exposed to intervention at the right age, but it's still being, melanoma incidence is still increasing based on the people who were unfortunate enough to miss that intervention. Now, we know, I showed you before, skin cancer and pterygium are correlated, so we looked at whether pterygium surgeries are also declining, and yes, they are declining Australia-wide over the last 30 years. So again, we expect that's a result of either the sun protection campaign or of just general behavioural changes. We see the same age-related differences. So the grey line here for females and males is the oldest age group. It's pretty static. The yellow and green lines are the younger age groups, and they're declining over the last 30 years. I did have a quick look at skin cancer and pterygium in Singapore. The rates of melanoma are very low in Singapore, so much less common a cancer. Non-melanoma skin cancers are the 6th and 8th most common cancers in males and females respectively, so still a reasonably common cancer. It's actually been increasing, so I thought it might be decreasing as your myopia rates are going up, but it's been increasing. It's this blue line here over the last 50 years, and that's I don't have enough context to explain that, so I'm sure some of you know more about that than I do. I've looked at the SEED study for pterygium prevalence, and again, there's quite a high rate of pterygium prevalence in Singapore, which is expected. It's a high UV environment. But in the group that's 70 years and older, it's about 17%. So pretty comparable to what we saw in regional Australia. So I've got a few minutes to finish up. And so I just will recap a couple of points and leave you a bit of a visual to finish on. So we've gone through how spending more time outside can prevent myopia and myopia progression. And there's very good evidence that it prevents both myopia and myopia progression. The effects might be stronger in terms of preventing myopia compared to preventing myopia progression. So it might be one that's best to get in early. It may be more effective in hyperopes than pre-myopes. So the people who need it least are probably the hyperopes, but that might also justify a public health approach because you're targeting all children, including the hyperopes, who will get the most benefit. Spending time outside might contribute towards seasonal variation, or it might come from the environmental changes with season, and outdoor time may interact with myopia control treatments we know it could probably affect your myopia progression, but may interact to modify the effectiveness of myopia control treatments. And that's really important because if we're going to prescribe a treatment, it also needs, if that's the case, if we're going to prescribe a treatment, we also need to be ensuring that there's behavioral changes or there are behaviors that are going to support the effectiveness of that treatment. But that leads to some questions as to how we best increase outdoor time. And looking forward to hearing some thoughts on that. And I do want to recap or remind you all that there's some really important non-ocular benefits to spending time outside, well-being. I didn't mention sleep, but if you're getting sunlight, that helps to train your circadian rhythm so you feel tired at the right times. But there's also harms to that. And so if we're going to look at sending kids outside in terms of reducing their myopia progression, we do need to be careful that we're not tipping the scales towards them developing sun exposure related eye conditions or skin cancers, and that's something we're very cautious of in Australia. So these are already quite common, and we don't want to, trade a reduction in myopia prevalence for an increase in sun-related conditions that are already quite a burden here. Because of that, in terms of our recommendations or what we tell kids who are coming in for studies, that there are actually some really safe times to go outside, and that's before the UV index crosses 3. So in Perth, there's about 3 hours outdoors before the UV index crosses 3 and 3 hours outdoors after the UV index drops below 3, where it's safe to go outside without any sun protection at all. Because if the UV index is 3 or below, that's the safe zone. So really encouraging kids to take advantage of that early in the day, late in the afternoon when the UV index is low. But then if they have to go outside during the middle of the day, then we have things like the Slip Stop Slap campaign that we can rely on, all the messages there. So and Seek and Slide. So just encouraging sun protection when it's unavoidable to be out in a high UV environment. So with that, I'll thank you and looking forward to some questions and discussion. Thanks so much.
Excellent. Thanks a lot, Gareth. Wonderful talk. I probably have like 15 questions, but I will not ask all of them. I'm sure Chensing and Janice have the same number. So again, let's start this panel discussion. I'd like to welcome Dr. Sun Chensing and Dr. Janice Lam, both pediatric ophthalmologists in the department at NUH Ophthalmology. And let me start by summarizing very quickly, Gareth, before we jump into questions. One thing that you mentioned that is very important, and we're always asked that question, is would time outdoors be useful if the kid is already myopic? And I'm sure Janice and Jensen got that question before. And it's important to highlight what you just highlighted today is that time outdoors is beneficial in general for health. So that's also in addition to helping interventions be more effective maybe, but also even if the kid is not on an intervention, it seems like there is some benefit for myopia, for slowing myopia progression in addition to the other benefits. The other thing that you highlighted that I think is very important to mention again is the side effects and making sure the kids are protected when they go outdoors. One thing we notice in Singapore is dehydration as well. So to add that to the list of components is the kid needs to stay hydrated while outdoors. And we are trying to launch multiple campaigns. On our side with Janice and Chensing, we're trying to boost time outdoors through digital tuning, digital behavior tuning. We inform the parents of every day of how much time the kid is spent outdoors and let them decide in a way whether they want to complement these hours. These seem to point through to useful findings as well. Question for you. You mentioned hyperopic, pre-myopic, myopic, right? It seems like the duration of time outdoors is less important for hyperopes, slightly more important for pre-myopes, and very important for myopes. Is that the situation? And is there a cutoff that we need to tell like pre-myopes, what do you need? What do you know now? It's like 3 hours outdoors. Whether that's feasible or not is another question. What is the consensus on the durations for these three categories?
Yeah, I don't think there's a consensus. So I
Okay,
would reluctant to throw my hat in the ring and say it's this way or that way. Um, Certainly, from some of the lab work, it's possible that people who have become myopic don't respond to signals that would normally slow eye growth in the same way that people who haven't become myopic. So there is some potential evidence there to explain why we see differences in terms of response to outdoor time between myopia, pre-myopia, and hyperopia. Um, I I would love to see more research in the space essentially before I say either way that there's a definite difference between hyperemia and myopia, but it would make some sense if there were. It's a shame in a lot of ways because, as I said, the people who need the least are probably the hyperopes, and the people who need them
right.
people are the people with myopia. So um, uh, it's the more we know about it, the more we can understand, the more we can give the best recommendations.
Sure. I would invite the panelists to chip in here. Maybe Janice from your side first, if you have any question, or you want to chip in on that bit.
Okay, great. Thanks. Hi, Dr. Lingham. Thanks so much for the talk. It's been very insightful. There were so many reviews as well as papers that you brought up that I hadn't heard of, but I have learned a lot. I mean, it's quite a recurring theme, right? That, outdoor time everybody knows, but exactly how much outdoor time and how do you gauge the outdoor time? And these are questions that, parents will ask us. Oh, does it mean that I have to put my kid out there when it's super bright, or what about evening? So how do you measure, without, for example, you have the recommendation for in Australia where if the UV it's more than 3, is that what you mentioned? They should avoid being outdoors. But in Singapore, we don't really have that, and parents don't actually carry around like, an index or something like that. How best or what's a simple way for them to kind of gauge when it's safe to go outdoors, without having all these gates?
Yeah. So I mean, in Australia specifically, there's an app that tells you what the index is. It's very good. It says sun protection recommended between these times, and I totally understand that it's not feasible to never go out in the middle of the day. But as a general rule, the UV index will peak in the middle of the day, so at midday, and decrease on either side of that. So the times of lowest UV are first thing in sunrise for the next couple of hours and a couple of hours before sunset. And they're the safest times in terms of reducing UV exposure to be outside. In terms of light intensity, okay, it'll be a little bit less intense, but it's still going to be very intense relative to indoor lighting. So we still expect you'll see a benefit in terms of reducing myopia risk or progression based on sunlight. And we do get asked, about sun hats and sunglasses, because they will reduce the amount of light going to the eye. But again, even with those, and this is data from Singapore, from lab, even with hats and sunglasses, you're still getting a lot of light into your eyes compared to indoor environment.
Yeah.
And you're cutting out almost a lot of the UV. So hats are certainly something we really recommend if you're going to be outside after when the UV index goes a bit higher. So at the moment for me it's about 9:30 where it crosses that threshold. So hats are really good because they're going to block the sun coming down onto your eyes from the top. You're still going to get some reflections. That's why you need some sunglasses as well. But it does cut out a lot of that direct UV hitting the eye.
So could I just ask, because this is a very, Singapore is land scarce, right? Not many people can find outdoor spaces all the time, or we are in like highly dense like population. So some parents have mentioned, can I just let my child sit close to the window when they're doing their work, or just look outside at the greenery at it in the distance versus, actually going outdoors. What do you think about that?
I mean, I think if the option is not outside, if you're inside not near a window or inside near a window, then I would definitely recommend inside near a window. It's okay, from our perspective as a researcher, we have to try and measure how much time you either spend outside or you spend outside near a window, inside near a window, or you're spending inside away from a window, and it gets more and more complicated. And not that we're not going to do it; it's actually absolutely on the way. I think Raymond's sort of pushing some of that work, but we just don't have the evidence, the scientific evidence, to say that you're going to get the same benefit from sitting near a window. That's probably because it's much easier for us to ask, do you go outside or not outside? But certainly, based on the way we think outdoor time works, then being able to sit near daylight and to be seeing things outside could bring some benefit. Probably not going to be a complete replacement for being outside.
Thank you. Thank you so much, Dr. Lingham.
Let me concur to that, Gareth. I agree. But if they can't go out, better sit next to a window until we figure it out, I guess, right? Chen-Sin, go ahead.
Yeah, I concur with Janice and Ray that lots of information on every slide, and I learned a lot from what you shared. In particular, I think slide 25, does outdoor time reduce myopia progression? I think there has been lots of debates among many researchers. A lot of people says that after myopia onset, outdoor time no longer reduce the myopia progression. There's no protection, but I think the review study that you have shown, as well as the individual study, clearly show that increasing outdoor time, although the effect size may not be large, that clearly shows a reducing amount of axial length elongation. So I think that's important to highlight to people that don't give up. After you're myopic doesn't mean that outdoor time doesn't work.
Yeah.
And I think it brings up more questions on what exactly is it in the outdoor time. I think you mentioned, is it the spatial frequency of the outdoor? Is it the sunlight intensity? Is that the spectrum? And I think now we are starting to get kids to wear spectrometers to have a more granular understanding of what it is. But I think even as it is now, without understanding what it is in outdoor time, we already can see that there is a benefit. And I think with more data coming out from our studies, having better understanding of what is the spectral composition and whether that plays a role, I think we will have better recommendation. And I look forward to more work from your studies. I think in particular, I think it's interesting where in Australia you have the issue of the UV damage, and a lot of times I get asked on whether putting on sunglasses under the sun where you block out the UV as well as the blue content, while that protects the eye from the harms of UV rays, would that strip away the benefit of sunlight in terms of myopia control? So what is your take on that?
So my message is that no, it won't, based on the best available, our current understanding and the best available evidence as it sits. Your point
Mm-hmm.
about blue light is interesting because if that were the mechanism or if it were a contributor, then we would actually recommend sunglasses that block UV but not blue light, which is possible. In which case there might be an alteration of the effect. But the best evidence is for daylight as intensity as the driving factor. And so, again, based on studies in Singapore, even wearing sunglasses, you're still getting a lot more daylight outside than you are inside. And that should reach thresholds that we expect to be beneficial for preventing myopia.
Yeah, indeed. And that study, Raymond Naja is part of that as well, where Professor Xiang Mei got mannequins and put send light meter behind sunglasses and showed that even doing that with sunglasses, you're still getting plenty of lux into the eye. I think what we still do not know is spectral composition, whether that makes a difference. So I think now all of our studies, we're getting kids to wear a spectrometer on their wrist. And the question is, what happens, what is the exact spectrum that's going into the eye and whether that has an influence. And I think that needs to be studied as well. Yep.
Thanks, Jensen. We'll take a few questions from the audience. There seems to be a glitch, so some of the questions are going to answer. So let's take a few that may have been answered. I'll start with the most maybe difficult one, Gareth. Is there a specific lux or illuminance that we are looking at to consider outdoor time for protective effect as protective for our children, especially when the weather gets really hot in the afternoon? That's the difficult portion. And the other one is, would you recommend them to go outdoors in the evening instead?
Yeah. So in terms of a lux threshold, we don't know is the short answer. It might the best evidence I think is from the Storm study, and they were looking at 2,000 lux as a threshold, 15 minutes outside, intervals of at least 15 minutes outside in 2,000 lux were what they found. They found that the people who achieved that had the least amount of myopia progression. So that's not, again, not a causative association, but it's a correlation. So that's kind of our best evidence that you're looking for at least 15-minute periods in 2,000 lux, which is not, that's easily achievable on a dim, cloudy day. And in evening. So even, okay, maybe if at sunset, right at the sunset, you're dropping below 2,000 lux, but if the sun's in the sky, you're pretty much getting 2,000 lux or more. And if it is near sunset, you don't need your UV protection anymore, so you can actually take them sunglasses off and allow a bit more light into the eye. So I expect it. I haven't measured it obviously in Singapore, but I expect it would be above the threshold most of the day.
Maybe I can chip into this since we measured it in our cohort. As long as it's not around 6:15 or 6:30 p.m., you still have enough sunlight, and you could take the kids outside even until 6:15, 6:30 p.m. And then after that, really the sun is setting, already set, and becomes the illuminance becomes lower, and you start getting exposed to different lighting conditions even outside. But yeah, that's what we have. I agree with Gareth on that aspect. And the other question is, maybe from what I gathered from Moon Yu Wong, the outdoor exposure for the risk reduction myopia is correlated with the presence of daylight. Are there evidence that the risk of reduction are similar when outdoors at night? I guess you answered that one, Gareth, but that's also, do you think moonlight or street lights would matter?
No is a short answer. No, we don't think they're generating enough light to sort of be beneficial in terms of preventing eye growth, and they're probably, I don't know the difference, but I'd assume they're similar to indoor lighting, and we know that indoor lighting is not going to help prevent your or reduce myopia progression or prevent myopia.
Right. So maybe ask Janice any question from your side, or Jensen?
No, I think I'm good. Thank you very much, Dr. Lingham. It's been very, very insightful.
Jensen?
Yep. Well, there's a question from the audience asked about what age for the child should we start advising increased outdoor activity? How do you counsel parents who struggle to get their kids outdoor due to academic pressure of lifestyle habits? So
Yeah.
that's a question that I get asked a lot in my clinic as well. So what's your take?
For me, I mean, it's a tricky one. Even leaving the academic question aside, even just convincing children they should spend more time outside, it's probably easier the younger they are, and then they get a bit older, they get a bit more resistant to it. And look, I don't have a magic bullet for you. We've been looking at things like whether organized activities can help, even eating food outside, but it might be uncomfortably hot in Singapore. I'm not sure. I'd be interested actually, Jensen, about what you tell parents in terms of dealing with.
Yeah, same. I think it's actually more important to get them early because especially when they are in preschool, in P1, P2, when there's no examination, at least in Singapore, it's good to cultivate them to have that habit. Because otherwise, because the Singapore weather is so hot, it's summer all year round. So most kids actually like to stay indoors at home where they have air conditioning and it's not sweaty outside. So once they get into that habit of staying indoors all the time, then it's harder to get them outside.
Yeah.
So there's another question in the audience that ask about the difference in seasonal variation. That I have that question as well. You show very clearly, I think, your data from Dublin versus Australia, where the hemisphere flip, and you see a definite change in the pattern of axial elongation. So there's definitely a seasonal variation somewhere, and just a question of what it is. So the question in the audience is asking about, could there be a difference in spectrum in the seasons of summer and winter? Do you see that? Sunlight spectrum.
Look, there could be. I just don't know. I think probably yourself and Ray might have a better idea. I mean, the angle of the sun coming through the atmosphere is what I'm thinking. And I know there's definite differences in UV because of that. But UV is absorbed by atmosphere. Shorter wavelengths might be scattered. So do either of you have an idea? I just don't know the answer to that one.
I think there are some spectral differences, but the main difference is really the length of the day and the availability of sunlight. And I think that's the major component, but there are differences. I think Rigmore has a few data on this, if I'm not mistaken. So it would be interesting to look at the spectrum as well. So maybe the last question before we wrap up.
Sorry, can
maybe
I just
to our,
ask?
yeah, go ahead, James.
Sorry. So Dr. Lingham, Ray, and Chinson, you might have this answer already, since all of you, I guess, are scientists. But I was just wondering, we mentioned about this like seasonal variation in like northern and southern hemisphere. Has someone actually looked at how far away are you from the equator, and how does myopia progression like differ? Like, are you the closer to the equator or further away from the equator? Like, does that, because you're talking about exposure of sunlight, right? And depending on the tilt of the Earth, I mean, this is all I remembered from. So it depends on, sometimes what makes summer and winter. If you have winter, you have shorter days. Summer, you have longer days. And then does this like correlate with how far away they are from the equator?
It's a good question. So we've got a student looking at a review of this at the moment. And the obvious, extreme example would be like the Arctic Circle, where people are living polar night and polar day at different levels. I haven't seen any results yet. I mean, I tried to do this with Perth and Dublin and some other data to sort of see if there's a graded, looking at the amplitude. Does the amplitude get bigger the further from the equator? And I don't know. I couldn't find it with that, but it was fairly limited data set. So, yeah.
Okay. And I guess suppose, for if you're talking about enablers and barriers, right? Like to going outdoors. If Australia actually has any tips and tricks, could you guys share it with us, please? If you have any ideas about, that.
Yeah, I mean, I don't think it's not necessarily any tips and tricks, and we're still hitting the same, some of the same barriers, I suppose, that you are. And there's so like cultural differences are so huge and so hard to overcome. And there's evidence from the US that if you move to the US and the longer you're there, actually the evidence also from Australia, but the longer you're in Australia or the more generations that your family's been here, the more time you spend outside. So essentially you become more similar to the host culture and then change your behaviors accordingly. So it's I
What
think
school-based? What
yeah,
about school-based like
school-based. So,
interventions that
so
you guys
we,
have
I
in?
mean, growing up, I never spent any time inside in school. So we would always be outside at
Mm.
recess and lunchtime. It wasn't an option to be inside. There was shaded areas, but we weren't allowed to stay indoors. I think that was the teachers getting a break. So that's a really ingrained. That's very common practice to not be allowed inside unless it's extreme weather.
Even now?
Yeah, yeah.
Even now, and you have your children as well? And all that?
Yeah, even now, yeah. So we have a no hat, no play policy. So if you don't have your hat and your sunscreen, you're not allowed to be out. Like you have to be in the shaded area. And the other thing is having spaces that are designed for people
Yeah.
who want to go outside.
Just to summarize this, I mean, it's very
Thank
context
you.
dependent. We do have surveys from primary schools, from parents to know what are the barriers and enablers. And I assume maybe, Gareth, some discussions we should have, in addition to looking at seasonal variability, is these comparisons between what we have in Singapore and what you have in Australia, because the barriers are sometimes very different, depending on the context and on the culture. So we do have to wrap up. Unfortunately, we still have a few questions, but maybe to ask Janice and Chensen together, have you noticed any change in myopia progression done on school holidays? Would school holidays affect myopia progression if you see the kids after the school holiday? Have you noticed any trend?
Jensen first?
For me, I don't see particular strong trends because the school holidays in Singapore are not as long as elsewhere. So we have a 1 month at December and well, 6 weeks in December and 1 month in June. So that period doesn't, I don't see a significant impact. But what I did notice for my own kids is that their axial length elongation rates are indeed slower, and choroidal thickness are thickened. For my own children, just because I measure them sequentially monthly. But otherwise, in the general clinical practice, I don't notice that.
Excellent. Okay.
So I think personally for myself, sorry,
Janice.
go ahead.
Go ahead,
Yeah,
go
no,
ahead.
just personally for myself, I think that it's quite difficult because you're seeing them every 6 months, and if you only had a 1 month of a holiday, 6 weeks of a holiday, there are a lot of confounders because you have the academic 5 months and then 1 month. On the contrary, I noticed is that during school holidays, children, they go outdoors a bit more, but they're also less compliant to other measures, such as like if they're on atropine as well, or if they're low myopes wearing glasses usually at school, but then they are off the myopia control lenses during the school holidays, then the reverse does happen. So yeah. Oh, well, food for thought.
Perfect. Just to complete the question, the last question was about dark adaptation. I heard from Chensen, we discussed that there's no reason to increase dark adaptation or to have changes in dark adaptation with myopia. So thanks, Chensen. And that's the last question. Gareth, thanks a lot for a really, really fascinating talk. And that's probably the longest discussion we've had. So that's excellent. I think the topic is very timely and very interesting. And the comparison between countries is also very interesting, the barriers and the enablers, but at the same time, the differences in daylight, the seasons. And from our side, we're trying to raise awareness about time outdoors and light exposure with the hope that the parents can take action, but we're nudging them as well with digital interventions. And we hope that we can collaborate further on the multiple topics you talked about. So thanks again, Gareth Lingham, Dr. Gareth Lingham, for this wonderful talk. And thanks to Dr. Sun Chen and Dr. Janice Lam for being amazing panelists. So to everyone, thanks again for attending. And we'll see you next month for the upcoming webinar, which is going to be on the 14th of April, 2026, same time with Prof. Kendall Davina Frick, and who will be talking to us about the cost effectiveness in eye care. an introduction to the latter. And this will be hosted by our own head of department, Associate Professor Victor Ko. So thanks again, everyone. And thanks again, Gareth, for this amazing talk. And we'll see you